see everyone. Thank you very much for joining us on our trauma module number 5. Originally labeled your 2025 approach to malunions and nonunions, but from some of our pre-meetings with our mentor, Dr. David Paul Beret, he coined this term fundamentals. So this is going to be malunion, nonunion fundamentals, and this is going to be the first part of the module. And we've reorganized AO Trauma North America online into this webinar, journal club, and fireside. So you can see we're here now in the webinar. And September 30th, there'll be a journal club and then a fireside chat with Hobie Summers and Dave Bray, all on the same topic. So please join for all of these assets. And I think you guys are going to really learn a lot. I know I will. Kudos to all of us at AO Trauma North America and you for participating. You can see here we're at module number 5, and we've done a couple modules before. I spoke with my colleagues today, and they do agree that module 5 will be the best module out of all of them. I mean, it's a pretty exciting module, and we're very excited about it. So it's going to be didactic, case-based. We're going to open up the Q&A for you guys to ask questions. Dr. Jeff Marasek is here and Dr. John Scalaro. And again, we'll have some literature support, some paradigm challenges in the journal club, and then really aggressive discussions with real cases and solutions in October. My name is Mitch Bernstein. I'm an orthopedic trauma surgeon in Montreal, Canada. And I'm joined by 2 of my co-fellows and friends, colleagues. Learn a lot from these 2, Dr. John Scalaro, who's at University of California, Irvine in Orange County, United States, and Jeff Marasek, who's not far away at Cedars-Sinai Medical Center in Los Angeles, California. Very, very good, busy trauma surgeons who are going to teach us a lot. All of our disclosures have been mitigated and reconciled prior to the webinar. So again, AO North America is an independent nonprofit surgical specialty society. We do not endorse or promote any product or commercial entity, and equipment here is used for demonstration teaching purposes. This module is going to provide a very practical, evidence-based framework for evaluating and managing patients with malunions and nonunions. We are going to focus again on fundamentals. I know people, I don't want to say they make fun of the AO Basic course, but it's basically the AO Basic course in an advanced applied manner. And you're going to hear Dr. Marasek and Scalaro talk about very basic things and applying it in a very advanced, simple fashion. And I think there's a lot of beauty in that, and I'm very excited to see that. So at the end of this session, you'll be able to describe the clinical evaluation of patients with suspected malunion, nonunion, including a very important physical exam to look at all the planes of deformity and how you do that to make sure you can generate an appropriate problem list. And Jeff's going to talk about that, and obviously talk about the etiologies of the nonunion and malunions, and then talk about how to fix it. So we are here in about 2 or 3 minutes. We'll hand it over to Dr. Marasek, and then Dr. Scalaro will end on the hour. Just a heads up, there is a Trauma Fellows webinar October 7th on acetabular fractures. And again, we have September 30th is the journal club, and October 21st is the fireside on the same module. So this is my case, okay? This is a 51-year-old male. He has a healed femoral shaft fracture. But you can see, and I see already Dr. Scalaro and Marasek are looking at this x-ray because they're like, whoa, wait a second. I know you got an old screw path here. It's healed. Maybe you should relax a little bit, Dr. Bernstein, because I'm not sure if there's bridging callus. So what happened to this guy? Like, what do you mean it's healed? So this is a 4-year journey for this patient. 4-year journey for this thing to get healed. So if you think about that with your patients, 4 years to have a non-union is a long time, and the disability associated with these cases are pretty long. So this was the initial surgery that I performed, and a couple months later, you can see, or you should be able to appreciate, there's a varus malalignment. You can see now the nails abutting this cortex, and there's some loss of fixation. That was revised with a blocking screw here to realign the patient, but that also didn't heal, and then eventually was revised again with some other techniques to get this to heal. So I think the point here I'm trying to make is these malunions and non-unions happen to all of us. You have two very really good surgeons here to help you with managing non-unions and managing malunions, but I would ask you also to reflect on how to prevent these in your acute trauma scenarios in addition to trauma reconstruction. So I'm going to hand it over to Dr. Marasek, and thank you all again for being here, and please use the Q&A.
Thanks, Mitch. You ended with the point that I tell our residents, which is it's much more fun to treat other people's non-unions than your own non-unions. So what we're going to talk about today is really how to get from a patient walking in your office to the point where you're ready to take action. And it seems like kind of crazy to devote half of an hour-long webinar to evaluating the patient, but I think that moment of pause and trying to recognize all that you can see before you even start is really critical, because you can't make a good plan unless you have good information. And I think how you go about collecting that information and what information you collect is super important. So this is going to be the patient that we follow. This is a 17-year-old obese young man who was involved in a bicycle versus car crash. He was on the bicycle. He went to a local hospital where he had this implant placed and was having some difficulties with limping, and so was sent to see one of my partners, who then subsequently referred him to me. And if you look here, this is not from orthosiatros, but there are some definite signs of either surgeon haste or radiographic evidence of a struggle, and maybe some clues to some other issues that are going on. And so we'll kind of walk through this case and how I evaluated it, and then take that process through some others. So I want you to be able to evaluate a patient with a non-union or a malunion. We're going to analyze the frontal plane deformity and a bit of the axial plane deformity, and hopefully determine the etiology of a non-union. And then John will take that information and show you how to put it into practice. So it seems a bit crazy, but I know this is not the pelvis and acetabulum webinar, but what Dr. Rout used to tell us was to seek disease. And I think that is extremely appropriate and relevant to this topic, because you can kind of look very superficially at a patient, or you can really dig in and try to find every component of their disease. And I think the more information you have, the better off things are going to be. So non-union and malunion are very similar. To me, a malunion is kind of like if you like to run and you run on a track. That can be good exercise. It can be really enjoyable. Non-union surgery is kind of like trail running, where it's the same thing, but they've thrown some rocks and some other considerations into the path for you. So two very similar enterprises, but maybe just a little bit extra there on the non-union that you need to contend with. The central part to both of these, I think, is really alignment of the limb. this is from the Paley textbook, and just a reminder of why our limbs are designed the way they are. So that kind of 3 degrees of varus that we, constantly quote at the proximal tibia and distal femur is positioned such that when we are in single leg stance and our ankle comes underneath our pelvis, that then our joint line is parallel to the floor. And when we have aberrations or changes to this alignment, we run into problems. And so these 2 diagrams, I think, are really critical to know and understand. If you don't commit them to memory, then commit them to a piece of paper that you have ready access to, because this is kind of what I think about all the time, whether I'm doing a retrograde femoral nail for trauma, or whether I'm evaluating and planning a non-union or malunion surgery. And I think understanding these is really hopefully the crux of this talk. When you get to be treating non-unions, I think you also have to put on a little bit of your detective hat and try to get as much information as possible. I chose Sherlock Holmes over any of the other famous detectives you may know because he was known for his keen powers of observation. And so really identifying things such as, where are their incisions? What did the patient mean when they said, oh, I never had an infection, but there's signs of infection, or when they said, this happened. So I think you need to really be an astute observer to how they're walking, how they're telling you things, and understand those. I think some of that is also looking at the x-rays and being more like CSI. The Weber and Czech classification is probably not all that important in terms of categorizing treatment types or research, but I think there is some utility to it when we are initially seeing somebody and including us into maybe what the problems were. So we're trying to diagnose where there was an issue, and understanding some of these key radiographic features can be part of the problem. So is this an hypertrophic non-union with that classic elephant foot deformity? Or does this appear very atrophic, like the bone is maybe not alive, or even could it be, a pseudarthrosis? And then putting that information that you've gotten from the x-ray into your problem list. The diamond concept was something that Janutis and Einhorn published about what is necessary for fracture healing. And I don't really understand it, or haven't been able to put it into practice in my mind. And maybe the issue is just me, but to me it's not quite accurate. To me, it's really much more that the mechanical environment, your alignment, the strain at the fracture site, and its interplay with the biology is what is necessary to get it there, so that they're not kind of all equal. It's the interaction between them that's really important. And so maybe it's more of like a biologic prism with some light from the mechanics that produces beautiful fracture healing. And I don't know if this is correct either, but it's helped me change a little bit how I'm thinking. So really, I kind of put things into this box or this grid. I like to think about things on the local and the systemic level. And I like to think about things from the mechanics and the biology. So the local mechanics would just be the strain, shear, other forces acting directly at the fracture site. Whereas the systemic mechanics would be the overall limb alignment. And the local biology is the actual viability of the bone ends, the ability to create callus or to engage in fracture healing, whereas the host biology or the systemic biology is what type of patient is it? Do they have diabetes? Are they smokers, etc.? And as you kind of look into these 4 categories, how can you optimize or change each of these to pursue your goal? And with those, you can generate a problem list that will then inform your next surgery. Yeah. So when I'm evaluating a patient, I think a lot of it really starts with the story and letting the patient share their story and trying to understand what the actual issue is and what their goals are. Because a patient may have a leg length discrepancy, but if their leg length discrepancy doesn't bother them, it's their knee instability, that may be a very different surgery than somebody who has pain at a non-union site. And so listening to what they say, for instance, I never had an infection, they just gave me some antibiotics. Well, they probably had an infection. Or listening to the things they tell you and asking good questions, I think is a really important place to start. The physical exam is also critical. So basic things, checking pulses, noticing where there are prior incisions, where are there flaps, is there active drainage? Take a lot of photos of the limb for later planning and to put in the chart. And every patient who comes in with a fracture done elsewhere or with a problem that was done at our hospital gets a prone rotational exam. And so you can see here on our patient who had his surgery done at the local hospital after his bicycle crash has a major issue with his rotation. And one should not be able to lay that way. And you really pick up a lot of issues with femoral and tibial malrotation if you take the time to do this. And so I would strongly encourage you to do that in addition to observing their gait, looking at their foot progression angle, etc. In terms of getting lab tests, I think at the bare minimum, the column on the left is what you want to get when you are looking for or looking at a non-union or malunion patient. So I want to know their basic health status. I want to know their hemoglobin A1C if they're diabetic. I want to know their pre-albumin and their albumin as a clue to their nutritional status. And then ESR and CRP as a screen for infection. I think taking that ESR, CRP, and white blood cell count and trying to decide are they infected or not and do I need to take cultures is really a kind of separate talk that's a little bit more FRI based. But I think at the very minimum, I want that information. If they're normal, that's one thing. If they're abnormal, then we are going to screen further and we're going to dig into this deeper. I think everyone is probably familiar with Dr. Brinker's paper about endocrine abnormalities and trying to identify those and potentially fix them. These are things that you can take off your problem list before you start working on people. And so sometimes we will do the tests listed here on the top, a testosterone, a vitamin D level, and some other minerals in order to help try to understand that. Sometimes we'll also order a TSH and a free T4, PTH, etc. But really, as I've gotten some colleagues in endocrinology who are much more interested in this, I do that less and less and just refer people for them to get a fuller workup if it seems necessary. So if you don't have a good reason, if it seems like based on the fracture, based on the injury pattern, based on the patient, this should have healed and you don't understand why, it may be worth it to send them for referral to dig deeper. And then the last thing that I think is really critical is to do high quality radiographs. So for me, that means orthogonal radiographs of the affected limb. These are calibrated so that we can measure and template accurately. We'll often get comparison films of the other side. And then I think it's very difficult to do any lower extremity surgery in a non-union or malunion sense without standing long leg films. So here we have standing films from our patient, and you can see kind of what would be considered a decent x-ray. The patient's hips are equalized by having him stand on blocks, in this case, a 1 5 inch or a little bit over 40 millimeters. You can see that puts the hips about level. The patella are forward, regardless of what has to happen with their feet to make that happen. So whether they're in-toeing, out-toeing, etc., doesn't matter. You want the patella forward, and you want this all on one calibrated cassette. A CT, sometimes I'll get in order to look at specific details particularly if it's an articular malunion. But more often I'm getting them to assess rotation, and we're getting slices through the femoral neck, the femoral condyles, and the syndesmosis to look at that. I think getting those proper films is really important. So you can see here drawing the mechanical axis on our patient. He has valgus mechanical axis deviation on both sides. His injured side is actually a little bit better than his native side. If you compare that image to this image on the right, you can see kind of what it means to get a good film. So this one on the right, I don't think is quite as good. His right leg is malrotated. The patella is pointing a little bit out. It looks like his foot is maybe not all the way flat on the block. And so you're going to get some maybe flawed information from this. And so it's worth redoing it and sending them back to your X-ray tech. The other thing you have to do is also, in order to put them on these blocks, you have to examine them and speak to them before you get this film. So it sometimes changes your clinic flow a little bit, but I found that it's worth it. And overall, I spend less time by not having to constantly redo these. Okay. So based on what we know, based off those standing films and orthogonal radiographs, our patient has genu valgum bilaterally. He's got a very, very large body habitus. He's got a retained implant, and clinically, he has some malrotation. We're going to expand this problem list and continue to work as we collect more information, but let's dig a little bit deeper. So again, a refresher, here's the alignment of the limb in single leg stance and what it should be with the mechanical or anatomic axes. And in order to analyze that frontal plane deformity, the mnemonic is to map the ABCs. And so we're going to measure the mechanical axis deviation, analyze the joint angles, and pick the deformed bone. I think taking it beyond that to identifying the apex of the deformity and bone cut level and what type of correction is going to be more in John's talk, and maybe the location of the apex and bone cut level are more about surgical planning and templating. So we'll leave that for today. So to work through the exercise first, here's a different patient with femoral and tibial nonunion. You can see that he's got varus mechanical axis deviation. We can draw the anatomic lateral distal femoral angles, or preferably the mechanical lateral distal femoral angles. And we can draw the medial proximal tibial angles. And so you can see here that his MLDFA is high, which means that he has femoral varus, and his MPTA is low, which means he has tibial varus. Okay? If we apply that to our patient, we can again see that he has valgus. His MLDFA is low on the left, meaning he has femoral valgus. And his MPTA is high bilaterally, so he has tibial valgus. Okay, and so that's gotten us this far, and then taking it the rest of the way, again, we'll leave for later for details of, osteotomy techniques. Again, here's our clinical assessment in the office. In order to evaluate that, we get this CT scan. And so what I like to do is to draw these angles. You can see that there is an angle, here and here. And then we take that same arbitrary horizontal in here. And so the femur minus the tibia gives us a little bit of antitorsion on the right. If we look at on the left, you can see from there to there that's an insane amount of antitorsion on the left, and there's really about a 75-degree difference in rotation. So quite a bit of malrotation. And then in order to assess the other part of the axial plane deformity, we're going to measure from a constant point, in this case the acetabular dome to the top of the cassette. They're relatively even. We've done a good job equalizing the hip height, but maybe 2 millimeters shorter on the left, plus the 1 5/8 inches that he's standing on. So 43 millimeters of indirect leg length discrepancy that we need to figure out how to address. Okay, and so now we can really update our problem list. We know we've got bilateral tibia valga, left femoral valgus, large body habitus, retained implant, 75 degrees of malrotation, and a 43 millimeter ILLD that comes from the femur. And if we put that in, we can kind of put our matrix out. So we know there are clearly a lot of systemic mechanical issues here. The biology is going to be an issue because of both his body habitus as well as and nutrition, as well as the fact that there was already surgery in a prior IM nail. Thankfully, there were no major incisions, and the local mechanics were acceptable. This healed. This is a malunion, not a non-union, so we don't need to worry about that quite as much. Okay. Let's apply this process to a couple other cases now. So here's a different patient who has a tibial non-union. You can see evidence of a prior ankle arthrodesis. They've removed some hardware. There's some broken hardware. He has a varus mechanical axis. So as we fill out our matrix and make our problem list, you can say there's obesity, diabetes, prior ankle arthrodesis, retained implant, broken implants, hypertrophic, diaphyseal non-union, and we hope that it's aseptic. And so looking at our matrix, what can we do to address these various issues, and how can we move it forward? Okay. Here was our choice. We did a proximal osteotomy at the apex of the deformity to realign the limb. We used a device that will compress that non-union as well as lengthen to address his leg length discrepancy. And once we get him where he's going, we convert to a trauma nail and he progresses to heal. And you can see probably a little bit of valgus, maybe because we did our planning off of those poor standing films. Here's another case, patient with prior bilateral open femur fractures after a motorcycle crash in another country, and presents for evaluation. There's the standing film, so you can see alignment on the left is good, on the right is quite off. So in this case, she's extraordinarily thin, maybe malnourished, low vitamin D, polytrauma, probably infected, femoral varus, broken implants, femoral malrotation, prior open fractures, and we can fill out that matrix. And then using that, we can address all of those things by changing the rotation of the femurs, altering the leg length, and her leg lengths are not even. These are two films that are laid next to each other, but she healed. So if we take it back to our guy now, how are we going to address this? What can we cross off the problem list to move on and move this forward? So you can see that in this case, we're able to correct the femoral valgus. We're able to give the patient a medullary canal that will be able to be involved in lengthening. We're able to correct that malrotation. Right? And so now he's left with just some tibia valga, a retained implant, and a leg length discrepancy, and we can begin to work on those as we see fit. So doing the evaluation of a patient with a non-union and malunion are very similar. You just need to do a little bit more detective work in the non-union setting. You're going to map the ABCs to analyze that frontal plane deformity, and then looking at the characteristics of the non-union can help identify some of that pathophysiology and fill out your problem list so that you can do the necessary surgery.
Thank you very much, Jeff. That was outstanding. I actually learned a lot, and I like how you put that matrix in there to execute part of the problem list. So let's move right along to Dr. Scalaro. And again, if you guys have any questions, please put it in the Q&A.
All right, thanks a lot, Mitch. Jeff, nice presentation as always. I think similarly, I just watched that and it just reinforces all the things that I think we always talk about when we even quickly discuss cases. And you realize that, a lot of, as you start doing this more and more, you're kind of routinely going through that exercise, but the fundamentals are have been kind of burned into our brains and really the core of doing any of these types of procedures. So I'm going to take, I guess, what I would just call part two, which is the approach to the patient with non-union or malunion. And um, objectives from my standpoint, I really want you to outline in a systematic way what factors contributed to a malunion or non-union. And I know Jeff had spoken about the fact that really in his mind they're two very similar things, and I couldn't agree more. I think sometimes it's difficult to see it that way because in one situation, right, a fracture is healed, it's just malaligned, but a lot of the same principles really um, you know, override both of those. You want to incorporate deformity analysis into your surgical plan. And so, one of the things, especially as I talk to the residents and um, when we're going through these kinds of things, taking full-length standing films, doing, good physical examination, evaluating sagittal plane deformity, especially at the joints, really tells you a lot about what your problem list needs to include when you tackle any of these. Um, I think a short talk is will be incomplete in terms of identifying all the surgical tactics to address and start checking off points on your problem list. But we have two excellent components of this module in terms of the journal club, and then finally with a very heavy case-based talk that I think will continue to add weapons into your armamentarium. So as I mentioned before, nonunions and malunions, similar but different, right? The malunion is a malaligned but healed fracture, and I think you just have to go back to existence before orthopedic surgeons. I mean, fractures want to heal, right? Oftentimes they may not heal in the correct position, and so your malunion may or may not even be a fracture that has been intervened upon or surgically operated on by another individual. It may have been casted or splinted or neglected or whatever you may have and have just healed. In my mind, I think it's nice to kind of put these two into or put malunions into two boxes. One, those that were never reduced or aligned, like the one that Jeff showed, right? There's a patient who was treated, had a femoral implant placed, but the fracture healed, but looked like it was never really put back together correctly. And then those that had some sort of fixation applied, and there was either loss of reduction or loss of fixation, and then that patient went on to heal. And those present a little bit more of a complex scenario because oftentimes you start to add to your problem list things like broken screws, broken implants, things like that are just things that you have to maneuver around and take into consideration when you start putting together your plan. The non-unions are a little bit different, right? And those are the unhealed fractures. And those can come in a couple of different varieties as well. There are some that are well aligned but just not healed. There are malaligned non-unions. And again, now you start to move kind of back into that malunion box where you have you know, an area a foci that is not healed, but you also have a malalignment that you need to correct. And so oftentimes as the non-union has progressed, there may have been bone resorption, there may have been hypertrophic or ectopic bone, in areas. You may be dealing with other issues that may be a little bit different. And then again, we talked about some of the various contributing factors, and one of my charges and my goals is really just to help you um, think about some of those and develop a plan to address them in kind of a simplest way. So malunions are fun because really you have time on your side. The fracture is healed. You can spend time and get a good history about the patient, the injury, get a good examination with regard to what surgical approaches were done. If you need to delve into you know what was done at the previous operation or whatnot, you can take some time. I think it's really hard to separate infection from either of these, but not really within the scope of this talk completely. And then identify the implants in place. So for this individual who is referred to our office who had a skiing trauma, followed by or had a concurrent head injury, has some ectopic bone, has various malalignment of the proximal femur. You get your standing films, you can start looking at leg length discrepancies. But one of the reasons I talk about kind of history and time is because this patient had initially presented to us, has a lot of things kind of on his plate with regard to his livelihood. And so, we had scheduled for surgery like 6 months after I had initially seen him, because he didn't have a tremendous amount of pain, and it wasn't like any of his implants were in imminent danger of failing. He had healed. He was just in poor alignment and disliked his leg length, and it was starting to have increasing hip pain. You can plan the heck out of these things. And so identifying whether you're going to do some sort of acute or gradual correction, figuring out what you're going to use for fixation. This is where a lot of the nice templating software comes into place. But most importantly, with all of this, is you want to avoid some sort of iatrogenic issue, right? And so, when we think about doing osteotomies or mobilizing areas that have been healed, we're thinking of being very aware of any sort of heat generation that we have. We don't want to create a non-union or an infection in an area that's healed. So we don't want to trade one problem for another. So this is very much about um, deformity correction and realignment. And so, in its most elegant form, valgus intertrochanteric osteotomy, compression with a fixed angle blade plate, and realignment and some functional excision of some ectopic bone for this individual gets him a very nice outcome. Nonunions, on the other hand, maybe a little bit more uh, complex in a way, because you just have other things to think about. And we talked about some of the classification. I don't really think that this is incredibly helpful, at least in my uh, mind, because you have the hypertrophic ones, the ones that are trying to heal. There's an abundant amount of callus, and those just need stability. So whether it's upsizing the nail, adding another plate, developing or creating some way to stabilize that fracture. The biology seems to be there. The allogotrophic and the atrophic is always some combination of biology and stability, and maybe your evaluation of the plain radiographs as well as the CT scan or any sort of advanced imaging can help you um, determine that. But really, you have to address both of them in any sort of non-union surgery you have. We mentioned infection, again, maybe outside the scope of this talk, but I think you have to investigate that with laboratory investigation, potentially intraoperative or a separate biopsy surgery or similar before you start placing new hardware. The alignment, as Jeff spoke to you about, I think is critical. And we'll talk about the importance of that. The metabolic factors, similarly, Dr. Brinkers has a couple of nice review articles. I think from my standpoint, creating just a workflow in your clinic or a typical order set that you utilize can just expedite this workup for you and for the patient. And then I think ultimately understanding the goals of care. We're so dialed into treating radiographs and measuring small changes in alignment and length. But if you have a patient who has pain from a non-union, maybe elderly or lower functioning, and simply just wants to be able to mobilize and be stable on their lower extremities, the goal for that patient is going to be very different than the patient who is a much younger uh, patient who is, you know, working, or is functioning at a much higher level. Excuse me for 1 second. I'm just going to close my door. Sorry about that. So think of non-unions, and I'll use ABS or ABS. It's just one way to kind of put a couple buckets together for evaluating non-unions. The alignment's important. It improves healing. If you can get a extremity and its near anatomic alignment, that improves the healing. It optimizes the fixation implants that you're going to use. And so whether you're using an intramedullary nail or a periarticular plate or a fixed angle plate, it really puts that implant at an advantage in terms of its function. In the upper extremity, I guess it depends on kind of which part of the upper extremity you're talking about. Obviously, with the shoulder and the elbow, there can be a greater amount of deformity that is tolerated and still result in a very functional um, uh, level for the individual. if you're talking about a forearm non-union or malunion, obviously that portion of the upper extremity works more like a joint. And I think, when I speak about this, I'm talking about extra-articular non-unions or extra-articular malunions. But understanding that, shortening in the upper extremity is dissimilar to shortening in the lower extremity, right? Because we're not weight bearing on our upper extremities. And so I think, people talk about non-unions in the upper extremity and shortening, and that's a very viable solution, whereas shortening in the lower extremity may be a viable solution, but may lead to a leg length discrepancy that is problematic for that patient. We spoke about full length standing films, physical examination, um, being patient focused. It's one of the things that I think is we tend to kind of gloss over because we're so dialed into understanding problems, listing discrepancies, listing differences, but the goals of the patient may be somewhat different than your goals in terms of treating that radiograph. So incorporate that into what you ultimately want to do. The biology is important, and the biology, Jeff talked about the local and systemic biology of the patient. When we're treating non-unions, oftentimes if it's been operated on before, there may have been damage or an assault to the local biology. And I think you'll hear a little bit more about this in our case-based study. But people would choose to add biology to the area that they're trying to get to heal. And so whether that's local or remote, in the upper image, you see a fluoroscopic image of a medullary bone graft harvesting device that can harvest a large amount of bone graft. But remember, any bone graft that you're getting from the patient is that of that host. And so if you're trying to harvest bone graft from an 80-year-old, it's going to be very different than that of a 20-year-old. People will have started to do aspirate and Cancellous chips, so kind of mixing autograft and allograft. I always or almost always recannulate the medullary canal if I'm doing some sort of diaphyseal non-union. I think it's incredibly important. It brings blood supply into the area. Osteoperiosteal decortication, I'm sure you will hear about in a couple of talks, but a technique where you elevate some of the periosteum and the soft tissue and decorticate the area of the non-union in order to stimulate some healing. And then kind of the penultimate way to improve biology is just to eliminate the area that may have dead or truly non-viable bone, and then start to get yourself into defect management, which is a little bit of a different conversation. Stability is incredibly important. So non-unions love to be compressed. And so whether you're using something like an articulating tensioning device, modified clamps, compressing, using two or three of these techniques in combination, if you have some sort of opposable surface that you can load, I urge you to do that at any, in any way, shape, or form. You can generate stability by using different implants, larger or longer plates if you're plating an area, additional plates, so using fixation in two planes, larger nail diameters, so reaming up a canal, placing a larger diameter nail, or using some sort of combination, which has started to become a little bit more popular, especially in the lower extremity with some of these more challenging non-unions. Bones like to be loaded, and so as soon as you can restore the ability to fully weight bear, that's important. And you want to get these patients who oftentimes have been stiff or not moving their joints the ability to comfortably mobilize. And this goes back to simple AO principles that I think are really important. And then again, depending on the uh, type of non-union you're going to be treating, oftentimes you may have to wait this out a little bit longer. So it's not going to heal as quickly as one of, as maybe an acute fracture or one that previously hasn't been operated on. And so you need to kind of have a construct that's going to be able to handle the test of time and maybe ride out for a little bit longer. So you want to give something that's stable. Some special considerations, and I'm not going to get into this too much, but I think multiplanar ring fixation is a great way to treat some of these. You can allow for angular deformity correction. You can compress or distract osseous segments. They allow for full weight bearing. The downside is that's an external device for the patient that requires care and maintenance. There are some mechanical medullary implants that exist on the market. Jeff showed one. and these can allow for lengthening or compression along the anatomic axis of the medullary canal. They can be combined in some situations with angular correction of an end segment. And again, kind of outside the scope of this, but I think not great for doing that to large degrees acutely, but oftentimes they can be mixed and matched. They do have weight-bearing restrictions, at least many of them on the market do right now. But the nice part is it's an internal device, and the patient does control this through some sort of external device that they utilize to communicate with the medullary implant. So for lengthening and compression, a couple other options. So let's get into a couple cases, and I'm going to go through these somewhat quickly because I want to be cognizant of time. There's a 63-year-old male motorcycle collision, 7 months following IM nail um, at an outside hospital. So I'm going to close this up really quick. Oh, shoot. My apologies. Did you guys lose my screen, or is it still up there?
No, we see your screen.
You're good.
Okay, it's for some reason I just lost my. Sorry, give me 1 second. I'm really sorry. I completely lost my screen.
Maybe stop sharing and
There
reshare.
you go. Okay, I got it. I'm back.
You got
Sorry.
it?
I am back. I think. Sorry. Anything changed here? Oh, here we go. Okay,
Yeah,
perfect.
there you go.
I clicked nothing and it just
But John, the suspense was good because this is a nice this is a nice case.
All right, so 7 months after fix, you see this proximal third femur fracture as well as a distal metaphyseal uh, femur fracture, and this patient continues to have pain. You can see that the patient is incompletely healed at both locations. Don't have any failure of the implants which are present, but the patient has a non-union. So, say a malaligned non-union. We have a CT scan here that gives us some identification of at least the local biology in the area. He's looks like he was trying to heal that proximal fracture. Same thing distally, maybe a little bit less biologic activity distally, but you get the idea. So the proximal segment was flexin and varus. The distal segment had a little bit of translation issues. There's fracture callus at both sites. We did a preoperative workup that didn't reveal any sort of abnormalities. The patient was a little bit of a larger patient size-wise, and there's a single implant used to fix both. But again, given the implant maybe limited ability based on the morphology of the fracture to stabilize both these segments. So, going back through my ABS, my abs here, correcting the proximal distal segment deformities, and I'm going to be using some provisional fixation to hold that while I place my dominant implant. I'm going to mobilize these with low energy. I really don't want to generate any sort of heat at these areas. I'm going to utilize the reaming from the medullary canal as local biology, and then make a determination if I need any sort of additional graft. But hopefully, if I can get these cortical segments lined up, then I'll be in good shape. And then provisional plates that
I'm
I
going to stop you really quick. I'm so sorry to do this, but the screen is flashing and we're just getting the same slide over and over again.
all
I'm
right.
not really sure why.
Okay, let me.
That'd be great. Yeah, if you just want to unshare and then start sharing again, that'll probably fix that.
Sorry.
I thought it was just me, and I didn't want to embarrass myself.
Is it better?
It seems stable. Yes, I think we're good. Thank you.
Okay.
Appreciate that.
No problem. I have no idea what's going on with my computer. I apologize. So provisional plates to keep my alignment, and then use a larger diameter nail to fix this. And so you was using an osteotome to mobilize the primary fracture line in that subtrochanteric area, and keeping it held in place with a mini fragment plate. And then you see a collinear clamp as well as another mini fragment plate in order to realign the distal segment. And I had end up having to use an osteotome as well, kind of in an oblique fashion, in order to mobilize that distal segment. And you can uh, imagine, I don't have a safe fluoroscopic image, how that collinear clamp was taking that distal segment and lateralizing it or medializing the shaft segment in order to get that area lined up. And so utilizing a medullary implant, submedullary implant, but blocking the previous path of the nail which had been placed before. And you can see I kept the mini fragment plates in place, and then use a longer and larger diameter nail. And so this is kind of what my final radiographs look like in the proximal segment and the distal segment, and really with no addition of biology in terms of bone graft. You see this patient goes on to a very satisfactory healing both in the proximal and distal segment by just restoring the anatomy. Simple restoration of anatomy and addition of stability gets this patient over the edge. The 64-year-old female, multiple medical comorbidities with acute onset of right hip pain after a misstep 2 years after fixation. And so this is one where you don't really have a lot of time on your hands to do a full workup. This patient now essentially has an acute um, breakage of an implant and in an area that's a non-united uh, proximal third femur fracture in the subtrochanteric area. And so, I'm not going to get her standing up on blocks or anything like that. She can't stand at all. And so you really have to, kind of work relatively quickly to get a plan in place. And so she has some varus malalignment that's acute. The proximal segment, and there's a different lateral radiograph that shows it's somewhat flexed. There's some callus present, but it's non-bridging. The edges are sclerotic. So there is some biologic issues in place, and the patient has a broken reconstruction style implant. And so I'm going to generate some valgus, correct the flexion of that proximal segment if I can, debride the nonunion surfaces, compress if at all possible, again using local medullary graft for reaming, and then using some cellular allograft if necessary. She was a 60, I think 64, like I said before, but she was physiologically much older than that. And we're going to increase stability with conversion to a submedullary implant rather than a reconstruction style implant, and then maybe use a supplemental plate if possible. And so you can see us mobilizing and debriding that fracture. I have a pointed tenaculum in place to give myself a good vector to correct both the flexion as well as that varus which was present. I actually use another modified clamp on the far left to almost accentuate the valgus there. And then you can see I have a conical nail extraction device, which was present in that previous nail path. Again, blocking the position of the previous nail so that I don't place an implant that falls into the exact same path as what she had started with. And so use a submedullary implant. You can see that I maintain my clamps. I have a plate in place with screws outside the path of the nail, which are holding that compression as tight as possible as that nail screams by, and maintain that plate post-operatively. And this is her final radiographs after she healed. So I didn't add any sort of local biology to this area at all. Just corrected her varus, improved her stability with a plate nail combination, and she goes on to nice healing. 21-year-old female, 9 months status post left femoral intramedullary nail, which was done at our institution. She has a history of osteopoikilosis, which I had to look up and refresh my medical school brain on. Doesn't cause any sort of issues with regard to healing. But she had a trochanteric nail placed for a rotational oblique femoral shaft fracture. Now, this is one where I really didn't see a lot of healing effort. And so this was unusual for a 21-year-old, right, with a large surface area. So her alignment was overall not bad at all, but I really didn't see any callus, which was the concerning part. I did a preoperative metabolic workup and didn't see no findings that were concerning to me. And she had good stability with her intramedullary implant. There was nothing broken, and the nail was appropriately sized, I thought, but just didn't go on to heal. And so it wasn't going to change much with her alignment, but know that I needed to improve the biology. And again, these fracture surfaces just wanted some way to be compressed. And I didn't think that just reaming her up and placing a larger diameter nail was going to work. And so I had to think a little bit outside the box on this one, and surely utilize my peers for their input. But I was going to increase stability with a dual plate construct to reduce torsion on a rotational fracture and really get this thing aligned. And so you can see some clamps that are in place have some lag screws across the obliquity of the fractures, and then a much longer plate. So I convert from a nail, which is obviously typical, to a plating construct, and then use a orthogonal plate for stability. And she healed this pretty rapidly, actually, just after conversion to a different construct. So, Mitch, I'm gonna hold for right now. Do you want me to finish off, or I have one more case, or do you want to?
I think finish off, John,
Okay,
and
sounds good.
I'm gonna just like get right into it because there's a lot to unpack there.
Okay, so you want me to just hold for right now, and then
No,
you
I
take.
would shut it down.
Sounds good.
Do you have a summary slide you want to use?
Do just I got it. So in conclusion here, so I just say non-unions and malunions, different but similar, in the fact that both of them require deformity analysis. You have to identify the causative factors and create a problem list. Remember the alignment, the biology, and the stability. And then, like I said before, the more techniques you have at your disposal, the more powerful you are as a provider. So, all right, thanks, Mitch. I apologize.
No, we're right on time. So like for me, outstanding. I'm like overwhelmed, and I'd like to take another hour of everyone's time, which we're not going to do. But let me ask you and Jeff something. I'm gonna try. I like analogies. I'm not sure it's gonna work. Are is what you're proposing approachable, or is this like a Michelin 3-star restaurant in Madrid? Like people are asking what size the mini fr like can people, like Jeff and you, is this doable, and how do you execute? Period.
Go for it,
Yeah,
Jeff.
I mean, I think
I mean,
the reason we're
you,
having this webinar is because while these problems are challenging, we try to highlight simple things because, when you make something, this isn't like you said, a 3-star restaurant. We're not like doing spherification of like, random crap. Where you're using what's available to you, nails, plates, whether they're small frag, mini frag, large frag, you can make all these things work. Yeah, maybe there's some couple crazy cases where you use some special implant, but for the most part, it's extremely principle based. And if you are thoughtful in your evaluation and thoughtful in your application of those principles, then it's achievable.
okay, let me get right to John, right practical question. What size were the plates in your nail plate combo where you had those mini frags? Someone asked.
I think it's the 2.4 or 2.7. A lot of the, I think I just highlighted, as Jeff was saying, a lot of these things are just things that we have off the shelf. I mean, we all do cases with maybe some less typical implants, but in general, I would say the vast majority of the fractured non-unions and malunions that we treat are fixed with standard plates and nails. It's just more the application of them and the thought process that goes into planning the surgery more than anything else.
So just for this, I am the boss here. I'm gonna let this run over a couple minutes. For those of you who are sticklers to the 1 hour, you may leave, but I'd advise to stay a couple seconds here, and please keep coming with the live questions. So another
This one's
question.
a good
Okay, go
question.
ahead, Jeff. Yeah.
Well, this one is good, but keep going. Sorry.
Oh, did you want what was the question?
No, there's a couple very good questions in the
Yeah. So, Jeff, do you want to answer this one? Any role of gentamicin injection fluid application to an infected or non-union site? Can you inject gentamicin?
I think you probably need an FRI webinar because a lot of these questions have been about infection. So to me, injecting or placing a powder is not particularly useful in the treatment of infection because they disappear so quickly. They can be useful in the prevention of infection, but again, you have to make do with what you have at your service.
Okay, so John, logic again, the logic in your last case had a nail, like you said, you sling the nail in, the nail's the standard of care for a femur fracture. How did you have the confidence, or what principles were you using to change it to a plate is the question.
Yeah, I think for me, I was just really surprised that I saw no or very little biologic activity in a 21-year-old with no other identifiable reason for not healing that. And so she has this long oblique fracture surface that it should put down something, right? But if I take a step back, what I do know is that fractures want compression, and as there's no violation in any way, shape, or form, during her initial surgery, or so I thought, of, I don't think she was overreamed and had some excessively large nail placed or anything like that. So, maybe some of it was initial thermal injury, but you know, it didn't get that sense. And so I just needed to change something up, and I didn't feel good about the fact that re-reaming and placing another nail was going to take her over the edge. And so yeah, it was a little bit of a leap of faith, but I tell you, like I've mentioned before, you guys probably don't remember this. You all saw that case because I showed it to you all, I think prior to a course, and I literally got 5 or 6 different people to weigh in on that case, and the predominant thought was that take that nail out and give it change it up, and if you can compress that those long oblique surfaces, that may be the winning combination. But it was a little bit different for me because it's a much bigger surgery than doing something percutaneous like an exchange ream nail.
And I guess the other thing that's important is how to, and everyone online should know how to do a lateral approach to the femur that doesn't strip the periosteum to the bone the entire extent. Okay, so we're not going to go over that, but that's also part of that. Do you ever use an antibiotic coated nail for septic non-unions? When do you use antibiotic coated nails?
Yes, Janet
Yeah, at least
has a great series on that.
Yeah, I would just add that I think oftentimes it can be used, at least in my hands, for staged um, management, depending on the patient. If I'm trying to eradicate infection, oftentimes I'm trying to eradicate infection before I do my definitive procedure. But there is, I think, some very good evidence for using it, as Jeff had mentioned, Jenna Conway series.
Jeff, some quick pearls on when you pull the trigger indicate a patient for surgery that hasn't healed yet. This delayed union diagnosis versus like practically when do you execute?
So I think the most clear cut, and John did a really great job of breaking this down, is there's a difference between a well-aligned non-union and a malaligned non-union. And as soon as it goes from well-aligned to malaligned, you're pulling the trigger. So if something breaks, if something shifts, or if it's malaligned from the start, I'm not waiting. If it remains well-aligned and it's not healing, then that's primarily a conversation with the patient and about how much time, how costly their time is to them. What's the opportunity cost of continuing to wait? And what other potential interventions do we have? Which is maybe not a very succinct way of saying it, but say, we haven't seen progression for a couple months now. Doesn't look like anything's happening. We should probably change something. And if they say, well, can we wait? And you say, yeah, you can wait. I don't know, John, do you have other thoughts?
Yeah, I mean, and that's why I said, figure out what the patient goals are, right? Because if you have someone who's got a diaphyseal femur non-union with a large diameter nail and multiple interlocks proximally and distally, but is going about their life with, you know, maybe a little bit of startup pain or something similar, probably unlikely that that implant's going to break. And so at that point, it's just when do you, you know, when do you want to pull the trigger? How bad are your symptoms, and when do you want to undergo an operation? And right, I mean, maybe you say never, but that's, I think ultimately, you know, we tell patients it's a race between fracture healing and implant failure. So at some point, there's going to be enough cyclical loading of something in most patients that they will start to have failure of their implants in some way, shape, or form.
In conclusion, I would say to you, find yourself some very good friends like I have in John Scalaro and Jeff Marasek, and collaborate well with your profession. You're always welcome here at AO Trauma North America, and hi to the other regions around the world who are watching. Thank you, April McKenzie from AONA. Thank you all for being here. Thank you very much, Dr. Scalaro Marasek, for spending time with us, and we'll see everyone soon.